accounts, and that is from Equity Pharma. Hey? Equity Pharma. They will handle the CPD points and upload it with the Health Professional Council. And I'm not sure the Nursing Council also do CPD. So hopefully they will upload it with them as well. We'll double check on that. Okay, so I think we'll start then. Sister Muriel is our first speaker. She's the breast care coordinator at Groote Schuur Hospital. And she's going to just take you through the sort of pathway that we use to diagnose patients in our clinic. How do they access the system? Where do they come from? What do we do? And then we'll take it from there. You can come, Sister Muriel. Is it? Okay, there we go.
So we're going to go from slide to slide.
Just the mouse.
Okay, good afternoon, everybody. First of all, I'd like to thank those who gave me the opportunity to speak to you this afternoon regarding our pathway, breast pathway at Groote Schuur Hospital. So thank you very much, Dr. Punt and Dr. Malherbe, for allowing me to speak here this afternoon. I actually want to start off right with our referral system. Our referral system gets done online. Now here's a problem because some of the patients are saying, sorry, I just want to click here. Oh, give me all the stuff. Okay. Right, so our referrals gets done online and our email address is www.gshbreastendocrine.co.za. So here we see symptomatic patients. We know they are normally referred to our diagnostic breast clinic, and this is done via online. So now some doctors phone or some nurse practitioners phone us and they say, but where is the Vula app? I've tried Vula app several times, it's not working. And every time I must tell them, please, we are not using the Vula app. We are on online. We refer patients online. So please bear in mind this afternoon, there is no Vula app involved in the breast clinic. Then secondly, when they refer the patient on the website, the patient normally tells me that the doctor said I must do it myself. They'll give the patient the email address and send the patient home, tell the patient to do the online referral, him or herself. Please, I want to encourage all of you this afternoon here. When you refer the patient, please, can you do it yourself? It is just better and it's just easier because there's certain clause on the email address that needs to be filled in and the patient don't have that information. So don't forget now, it's www.gshbreastendocrine.co.za. Then our diagnostic clinic numbers. Sorry. Yeah, our diagnostic clinic numbers. We have two clinics, first of all. One is a Wednesday. It starts from 7 in the morning. And on a Wednesday, we see about 24 new patients. And then from 6 to 10, between 6 and 10, we see follow-up patients. Then on a Friday, there's also another breast clinic, which is from 7 o'clock and 9 to 7 and 9. So there's two slots there. From 7, patients come in, and there's another slot for 9 o'clock. Here we see 48 new patients. And then also, there's 20 to 25 follow-ups that we see on a Friday morning. 60 patients are called per week because we also have a telephonic clinic or telephonic clinic service. And here normally we phone all the follow-up patients. So in total, we process or we see about 170 patients per week. Then our initial consultation, our patients are divided by age. There is the less 40, and then there is the above 40. They are seen by the doctor, and in our consulting rooms, there is a doctor normally, or there is a nurse helping or assisting the doctors. The doctors do the following. There's a history taken from this patient. And after the history, there is also an examination done for these patients. Now you will see these little 3 columns here. Our under 40 patients, that is a patient with a lump. If there is a lump, we will do an ultrasound. We will do a core biopsy, and we'll also do a telephonic clinic consult. And there is a treatment plan also that is following afterwards. Then we go to the over 40s. If there's a lump, we will do a core biopsy again. We will do a mammogram. After 2 weeks, we will do the mammogram after the biopsy. And there's also a telephonic clinic result and treatment plan involved here. Then there's other symptoms. And other symptoms, we do the following. We do a mammogram, if indicated, and then also telephonic clinic and treatment plan after the consultation with the patient. Now the triple assessment. The triple assessment is completed for all patients 2 weeks after the first visit, okay? Patients with a normal breast examination wait 4 to 6 months for an elective mammogram. So what happens if core biopsy shows breast cancer? What happens there? First of all biopsies are checked the week after they are done. And this is where I come in. Apart from assisting in the clinic, I checked every week biopsy results. Every week, in fact, every day, I check biopsy results. If the biopsy result is positive, right? We call the patient in. All biopsies from the breast clinic are fast-tracked at our lab. It's get done very quickly. Results are usually available by the Wednesday, the week after the biopsy was done. Then patients with a positive result are phoned and seen by the oncologist, the breast clinic, on a Friday, first week after the biopsy was done. So I normally call the patient if it's the positive result. I would call the patient the Tuesday or the Wednesday for the latest. I will call the patient and ask the patient to come in. And when I do the call, the first thing patients do is they cry. I tell them to come in, and I ask them to come in with family because it's very traumatic for them, you know, to come in. Then oncology is only at the breast clinic on a Friday. So please, I want to ask you, if you refer patients with known cancer to a Friday breast clinic, refer them to a Friday breast clinic and not a Wednesday breast clinic. Because remember, our oncologist is only at our clinic on a Friday. The oncologist is not there on a Wednesday. So that means that patient must come in twice for the week. And it's very, very expensive. If you are a pensioner or if you are unemployed, it's very expensive on that patients, even if you're from a country, because there's not always transport for these patients to come through. So when it is known, breast cancers, please refer them on a Friday to our clinic. Then we also have a telephone clinic. Most of the follow-ups at the clinic are done telephonically. Once the triple assessment result is available, a senior consultant reviews the results and make a treatment decision. Now, there's some arrows there. So it consists of the following. We will, if there's nothing wrong, we will either discharge the patient, we will discharge them, and then if we need to have further investigations, we will have a follow-up imaging, and that is usually a repeat mammogram or an ultrasound within 6 months' time. Some of the patients gets recalled back to the breast clinic where we do an ultrasound-guided biopsy, and repeat clinical examinations are done on these patients. Then our breast cancer numbers. We diagnose 10 to 17 new breast cancers per week. 10 to 17 new breast cancer patients per week, and about 600 new breast cases per year, new cancers per year. On average, we have 20% of the new referrals, on average, 20% of the new referrals have breast cancer. Prior, it was a walk-in clinic where everybody could just come in. But now we are so much well controlled, and we manage our patients very well when it comes to the online referral system. So those who are referring patients, well done to you, because it is positive breast patients that we are receiving from the Greater Cape Town. Oncology first visit. Usually patients are seen 1 week after the biopsy at oncology. The diagnosis is given to the patient. Then there's a brief explanation of what to expect in terms of treatment. Decisions are made on what staging examinations are needed. There's a CT scan, there's a bone scan, there's x-rays, there's liver, and there is an ultrasound. Patients that are non-metastatic and operable are booked at our combined breast clinic. If there is a suspicion of metastasize, or if they have locally advanced disease, they are booked at LE3 for neoadjuvant systemic treatment or palliative care, which is very sad. Then combined breast clinic. This only happens once a week, and it is normally on a Wednesday. So remember, we have a morning clinic on the Wednesday. From there, we rush back to the combined breast clinic, and afterwards we see the patients. So Wednesday, it starts normally at 1 o'clock. We have a multidisciplinary team, and these people are the following. We have our breast surgeons, we have our clinical oncologists, we have a pathologist, we have our radiologists, we have our plastic surgeons, and we have our breast care nurse practitioner. Patients with non-metastatic or operable breast cancers are reviewed, and they are seen in the clinic. So imagine the long agony of patients, because some of them come with health need transport, and they sit there from 6 in the morning till 4 in the afternoon, which is quite long. Then treatment plan formulated and dates for surgery or chemotherapy gets done there. Then it's psychologist, patient navigator, genetic counseling, social workers, palliative care, and are available in the hospital, the Greater Hospital, but they are not there that day in the clinic. But the services are available. So what happens after the initial treatment, however? The low-risk patients with DCIS are followed up in the breast clinic. Low-risk invasive breast cancers are discharged to follow up at the hospital, and high-risk invasive cancers are followed up in LE33, and that is for 5 years. What do I do if I suspect cancer, cancer recurrence or metastasis? The local recurrence of the breast cancer in the breast mastectomy or the under the axilla is seen at the diagnostic breast clinic for tissue diagnosis. Symptoms of distal recurrence: there's shortness of breath, new onset bone pain, backache, neurology, that is an emergency, and then there's jaundice or abdominal pain, persistent headache, neurological fallout. All these patients get referred to LE33 directly. And please, I want to speak to our day hospitals here. When the patients are known to them with metastatic disease, what they do, they send the patients here always on a Monday or a Tuesday to me, and the patients are in a lot of pain. They send the patients to casualty. The patients, they simply refer their patients back to me. And please, 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 those patients will lie there because there's no doctor to see them. There's no morphine to give to them. And they lie there in agony and in pain. So please refer them directly to LE33, not to Sister Muri, the breast sister on the G floor. Then my contact numbers are as follows. It's 021 402 5426, and that is Sister Muri, myself. I get, my phone rings non-stop. I can promise you that. It rings non-stop. Then there's 021 404 5523, and that is our diagnostic breast clinic. And then also we've got 021 404 4514. That is Rugaya Abrams. She's our secretary. She can help you with bookings. She can help you with queries, whatever you want to know about our breast diagnostic clinic. Then there's 021 404 4379 or 80. And that is referrals back to LE33. If you'd like to speak to me, you can either phone me or my email address is serena.muri@westerncape.gov.za. If you want to know more about our breast clinic and what we're doing, that's breastsurgeondoe@gmail.com. Thank you.
Mary, before you go, let's just
Yeah, 279 or 272 or 280.
Okay,
Oh,
so
sorry, 42. Yeah, 42.
shall I change it somewhere now?
Oh, sorry.
This
sorry,
one.
sorry. Yeah.
Whoops.
Oh,
So I think if people maybe take a screenshot of this, let me just change this to the right one. 4280.
Yeah.
Oops, like that.
Yeah.
So if you take a screenshot of that or take your camera, your phone and take a picture of that, then you've got all those numbers with you. Is there any questions from the room? Anything that's not clear? Anything that someone wants to ask? I just want to see in the chat room. There's some questions here. Will this video be available at a later stage? Yes. So we're recording it and we'll make it available to the cloud. So yeah, so we'll make a plan. We've got your email addresses as you've registered. So hopefully we can make it available at some stage. Are there specific drainage areas someone is asking? Not really. I mean, all the patients come to us at Groote Schuur. We've also got one satellite breast clinic for the Mitchells Plain patients. So patients that drain to the Mitchells Plain Hospital area will go to Mitchells Plain and they'll be seen there. But often that clinic only takes 10 new referrals per week. So there's a need for more than that, but that's what they can cope with in terms of staff numbers at the moment. So often what I do is when that waiting times go to about 2 to 3 weeks waiting time for a new patient to be seen, then I will close that clinic and I will divert the patients to Groote Schuur. So sometimes when you click on the referral form for Mitchells Plain, you'll see that it will just, the message will come up saying the clinic is at the moment it's full, and it will give you a link to the Groote Schuur clinic form, and then we will divert that patients to Groote Schuur until we get the waiting times down again, and then I will open that clinic up again. But yeah, it's only those two clinics that's available, Groote Schuur and Mitchells Plain. Hope that answers that question. Okay, so that's fine then. Sister Muri, you can go. So our next speaker is Dr. Liana Rood. She is a sessional consultant in the breast unit. More than a sessional consultant, you can pretty much call her full-time, to be honest. She goes through all those telephone clinic patients. She's the one that actually makes those treatment decisions. She's in the Wednesday clinic, is her clinic. So she's overseeing the Wednesday diagnostic breast clinic at Groote Schuur. And she also does quite a lot of private work. So she's a busy girl. She has got a private practice in Somerset West. So she's going to speak to us. We've swapped the patients, the talks around a bit because she's got to go to theatre and she's got to go and do some operations. So she's going to give us just an overview of what is breast cancers and how do we treat them, how do we approach these things. So thanks, Liana.
Thank you so much, Lydia and Francois, for organizing it. And it's lovely talking to all our referring clinicians. I think this is so valuable for everybody. I'm just going to move this window a little bit so that you can see. So really what I want to talk to you about is your patient's breast cancer journey. So Sister Muri has so beautifully now explained the nitty-gritty of the logistics that the patients go through. But what I hope to give you today is language to talk to your patient, because in truth, we try our very best to explain things to the patients, but our contact time with them is actually quite limited. And you are the people that they go back to. When they go back home, when they're worried about something, they go back to their GPs, they go back to their nurse practitioners. And really, you have so much power to, you know, put their minds at ease, to notice problems early, or to explain things better than we were perhaps able to. Or, you know, when we see them, it is like a wave of information coming at them, and it's so stressful and it's so emotional that I think a lot of it goes over their heads. So this is my attempt to give you language to actually talk to them about what is going to happen, what they can expect, why certain things are happening, to remind them and to actually just empower you also to understand their journey. And why this is so important is because there's a lot of noise outside. You know, whenever, just Google is so freaking dangerous. The things that patients come up with, the things my auntie's neighbor's daughter happened to her, and, you know, and meanwhile, it wasn't even cancer, but, you know, the doctors killed the patient. Or if you go to that hospital, you will die. Or if you get chemotherapy, you will grow two horns. You know, it's the things that people read, that people are being told. It's extremely confusing. It is very scary. And it's really our job to try and help them understand, you know, what we are trying to do truly is evidence-based and is safe and is what we believe is best for them. So to just quiet all the noise out there. So really, Sister Mary, I've explained the referral pathway so nicely to you now, but basically that referral form that's attached to the online referral is so important. And the reason is all those questions that we ask, and I've had patients asking me, why are you asking me all those questions? Because it's not questions we usually ask with a normal consultation. And that is because that form has specifically been designed to risk stratify our patients. You will see that all of those questions, when was your first menstrual period? Are you menopausal? Are you on hormone replacement therapy? Do you have a family history? All of those things is basically a way to elicit known risk factors in a patient. And that helps us. So when the patient sits in front of you, you already have a risk profile for this patient in mind. So that's the triple assessment that your patient is going to go through. Your clinical assessment, a very important part of that is actually the history taking and the conversation that you have with your patient. And you guys help us a lot with that already by completing that form. And then, of course, there is your clinical examination of the patient, where we do a full, a quick general examination and then a full complete breast examination, looking at the patient's concern, whether it's pain, whether it's a lump, skin changes, nipple changes, you know, all the danger signs that we look for when we are concerned about breast cancer. So part of the triple assessment, and this your patient then can expect when after they've had their consultation with one of our clinicians, is to get a tissue diagnosis. If there's a palpable lump, we need to look under the microscope to see what's going on. So they will have that tissue diagnosis and that biopsy on the same day as their clinic appointment. You can get a tissue diagnosis by two means. So you can either do a fine needle aspiration where you look at cytology, and with the cell block, you can also get some information, but that is not our preference at Groote Schuur Hospital. So we prefer doing core needle biopsies, because from the core needle biopsy, we can get a histological diagnosis. And that is super important, not only to make the cancer diagnosis, but to actually plan the management of the cancer. And I will come back to that, because that really is a key part also for you to understand when you talk to your patient about their diagnosis. And then, of course, the last part of the triple assessment is imaging that needs to be done, which is an ultrasound and a mammogram, usually both. You know, we say that our younger patients, usually there's this thing about under 35 gets an ultrasound, over 35 gets a mammogram, but I think that's a little bit of a misnomer. Mammography and ultrasound gives us different different types of information about the breast, and it's really all about breast density rather than age. So you can have a 55-year-old patient that the ultrasound is much more valuable than the mammogram, or a 25-year-old patient where a mammogram actually gives you plenty of good information. So that is in general, when you're booking from the outside, that above 35, under 35 is a good rule to follow. But when we are concerned about a breast cancer diagnosis, we tend to use all the modalities that's available to us. And breast MRI is usually reserved for our younger patients and our extremely high risk patients. So now we've had the lump, we've made the diagnosis, right? This is in fact a breast cancer. So really the steps or the flow diagram that your patient will go through is the first step that Sister Muri often helps us with. The first consultation with our oncologist is very important with, and where you also play a very important role. And this is actually naming the cancer and explaining the cancer. So we will do a little deep dive in that. Then your patient can expect, so you can tell them, you know, the next step is because they just want to, I've got cancer now, you've got to operate me tomorrow. It doesn't work like that, because the more information really is power. And we need to know everything there is to know. We don't like surprises. So a lot of our patients will require at least basic staging investigations. So for some patients, that's a chest X-ray and an ultrasound. For some, that's a CT scan, but they have to be prepared that there is going to be a period of further investigation, which is normal and is necessary. Then we will see them at our MDT, at our multidisciplinary team meeting, like Sister Muri explained, and I will use a patient example just so that you can get a feel of how a discussion like that goes. And then your patient will enter the treatment phase, which is different for every patient. And then the very last step, where you also play an incredibly important role, is survivorship and the follow-up of the patients. Okay, so naming the cancer. So this is really important. Just in broad, to remind you, in general, breast cancer, we usually have our very early cancers, or our in situ cancers. It's almost like precursor cancers, which can be ductal or lobular, and there's different subtypes of that. And then we have our invasive or infiltrating carcinomas, of which we've got various subtypes: the ductal and lobular, mixed ductal lobular, or of non, or the invasive cancer of no specific type is your most common ones. But so that's nice and it's fancy if you know the names, but actually we don't care that much anymore. We used to, but not as much anymore, because really what we are interested is in the biological personality of the cancer. And this so since 2012, since the St. Gallen's conference, we've moved away from classifying breast cancers according to their histological subtype, but now rather looking at them according to their molecular subtype. So we have our luminal A breast cancers, our luminal B breast cancers, HER2 overexpressed breast cancers, and our basal-like breast cancers. So what we look at when we look at this biological personality of a cancer that really determines how we're going to treat this cancer is we look at how sensitive it is to estrogen, so how the estrogen receptor status, progesterone receptor status, HER2 receptor status, that's our human epidermal growth factor receptor. We look at the proliferation index, which is basically a way of saying how quickly does the cancer cells divide. So how aggressive it is, in inverted commas, if you want to translate that for your patient. And we use all of that information to put the cancer in one of these categories. Okay, so I always, when I speak to the patients, this is how I try to explain to them. I tell them because this is also something that they will come and ask you. I've got breast cancer, my neighbor's got breast cancer. Why is she getting chemotherapy and the doctors are not treating me properly because I am not getting chemotherapy? So is to understand that each patient's breast cancer is different, and therefore their treatment journey is different. So I always tell them the botas from Benoni is not the same as the botas from Brakpan, or in Cape Town, botas van Bellville is nie dieselfde as die botas van Bothaville nie. It's different. It may sound like the same family, breast cancer, but they've got different personalities. Okay, so different faces, different personalities. So if you talk about your luminal A cancers, that is your cancers that is very sensitive to estrogen and progesterone. I always call them quite friendly, amicable Aunt Alice. You know, they are actually quite docile, relatively friendly cancers, and that's a way to explain it to the patient. Then your luminal B cancers, which is somewhere in middle, I call them not so nice Uncle Ned, because they look quite nice, but they're actually not that nice. And they've got a higher proliferation rate. They are often estrogen and progesterone positive, either one of the two, and they may have also HER2 positivity or not. So our mean but manageable Marthas are usually our HER2 overexpressed cancers. They are quite mean, but if we give them the right treatment at the right time and in time, we can manage them very well. We've got our surprisingly mean Seras, which is our basal type-like cancers, and our crazy Kims, which is our triple negative cancers, which are really, you know, quite nasty, quite mean, can be quite aggressive, but again, can be so treatable if we, you know, find it at the right time. Okay, so very important to know that therefore each personality asks for its own special treatment. So the type, the timing, and the combination of all of these things is different for each patient. And the combination that we work with and shuffle around is surgery, endocrine therapy, and we must always, in our younger patients, also consider their ovary. So sometimes ovarian suppression goes along with the endocrine therapy, chemotherapy, our biologicals, immune therapy is, you know, coming about. One of these days we'll be using hopefully that as well, and then radiotherapy. Okay, so those are the treatment modalities that your patient will be presented with, and like I say, for each patient the combination of this and the timing of it will be different. So some will start with chemo, some will start with surgery, some will start with a hormone therapy, with the endocrine therapy. Okay. So staging, we've already spoken about it. So really depending on the patient's age and whether we are, whether there's already nodal involvement, we will do a combination of chest X-ray, abdominal ultrasound, CT scans, chest, abdomen, bone scans, all of those modalities will be done. And then we see and meet our patients at the MDT. So I thought best to explain the MDT by, you know, an actual, say, patient example. So let's say we've got a 34-year-old patient now. She's a Grav1 Para1 female patient that presented with a breast lump. On imaging, it was a BI-RADS 5 lesion. So for those of you that's looked at mammograms, that is the classification system that we use. And clinically, it was a T1N1 lesion. So a fairly small lesion, but we could already feel a lymph node. So she's had a history examination, she had a risk stratification, she had a tissue diagnosis, and the biopsy result shows that she's got an infiltrating duct carcinoma. So when we get together at our MDT, when we meet, somebody will present this patient like I've just done. Then we will turn it over to our radiologist that will show us her imaging. So we will look at the imaging and ask, do we need more imaging? So has she had a mammogram? Does she need an extra ultrasound? Should we perhaps consider an MRI? Did we do all the adequate staging investigations? And we'll review all of that. Then the pathologist will come and they will show us the slides of the histology, and we will discuss that result. In her case, it was the infiltrating duct carcinoma, very sensitive to estrogen, sensitive to progesterone, HER2 not really expressed or negative, with a fairly high proliferation rate, Ki67 of 60%. So then we should say, okay, but this is a 34-year-old patient. That's quite young for somebody to be diagnosed with breast cancer. Does she have a family history? Should we perhaps refer this patient for genetic counseling and testing? Because that may impact her management and may also impact on her family. When we meet we will also, when we meet the patient, now we need to decide, okay, how are we going to do it? In terms of the surgery, when are we going to do the surgery? Before or after other treatment? And then if we are going to do surgery, are we going to do breast conserving surgery, which is just removing the lump, which is very fair. She's got a very small isolated lesion, okay? Or are we going to do radical treatment for her? If she, for instance, have a genetic mutation, it would be wise for us to not just do a lumpectomy, but to rather do a bilateral mastectomy for her. So those are all the things that we are considering. We also have to think about what are we doing with the axilla? Are we putting in a chemo port? You know, there's all of these things. Plastic surgery will be there if we need to think about reconstruction. This is a young patient, 34 years old, so still in her reproductive years, very estrogen sensitive. So now we have to say this patient cannot fall pregnant under any circumstances, but we also can't put her on oral contraceptive because it's got hormones in it. So we need to refer to the fertility clinic, put in a copper T that's safe, that can prevent pregnancy, but we also have to figure out where she is on her fertility journey. Does she have children? Does she want more children? And is there perhaps something we can do to assist in terms of future family planning? Because we are going to basically put her into early menopause for at least 5 years with our treatment, with the endocrine treatment that we're going to prescribe. So oncology will decide on neoadjuvant or adjuvant, endocrine, chemotherapy, radiotherapy. If you're in private and you are very fortunate, these patients can also be seen by a nutritionist and a dietitian, by a psychologist and a counselor. In our setting, Sister Muriel and our social worker does the hard work in terms of support of the patients and then finding them a support group. So that's basically what the MDT is all about. So when we look at the treatment, just very briefly, so you now understand that the timing and the combination differs for each patient. But basically, when we look at the surgery, we need to think about it as surgery to the breast and surgery to the axilla. Those two things always go together. Okay, the axilla, we're looking for nodal involvement. So when we look at the breast, we can either offer a patient a radical mastectomy, which can be unilateral or bilateral, and it can be with or without reconstruction. That's very much dependent on the patient's age, risk factors, the size of the tumor, whether we're concerned about multiple tumors in the breast or whether we're concerned about perhaps DCIS surrounding the tumor. So those are the factors that we consider when we think about it. Or just a lumpectomy, removal of the actual lump, which we always have to combine with radiotherapy. If we look at surgery to the axilla, so that's looking at the lymph nodes, less is more. We're really trying not to do radical lymph node dissections for patients anymore. If we can avoid it at all costs, we rather do something called a sentinel lymph node biopsy for them, where we can determine if in fact there are some nodal involvement. If there is obvious involvement, unfortunately, we'll have to do a radical clearance for them, in which case, again, you may see them later with problems of lymphedema, swelling, etc., that you have to be aware of when following up these patients. And then, of course, there's reconstruction. So in terms of the oncology side of the decision, your patient may be presented with any or all of these options. Chemotherapy that can either be before or after surgery. There's different types of chemotherapy that we can consider, depending again on the patient's risk profile and the age and all of those things. And then in private, we also have the advantage of using modalities like OncoDX or MammaPrint that can actually guide us in the, it's about the genetic profiling of the actual tumor that can guide us in whether we should consider chemotherapy or not. Endocrine therapy or the hormone blockers, tamoxifen, Arimidex, those are the names that you may be familiar with. That can either also be used before surgery or after surgery, and the different types. Radiotherapy, you can get short course versus long course, and for some patients there's different fields that we can include, so either we will include the breast and the axilla or just the axilla. And then there's our biologicals that hopefully will be available soon to our patients too. Okay. And then, of course, really very important, and Dr. Punt is, I think, going to have a good discussion with you about it, and that is the follow-up and survivorship. Because I often see this with patients is, the treatment is like go, 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 and they're holding it together because they've got something to do, they've got something to get through, and then all falls apart when everything is over, because it's like the realization of what's just happened actually hits them, and then it's like they feel like they're living with a sword over their head, and there's this tremendous fear. There is this almost a struggling to adjust back into the normal world. And this is where I think you can make a huge difference, where patients have to deal with the side effects of treatment that they're still holding over, the psychology of dread that many of them suffer with, lifestyle changes that's important for them to make, certain coping strategies that they can be taught. This treatment has a tremendous impact on their sexual health and their relationships as well. So to have those conversations with the patients openly, to have available support groups, and to remember that this patient's diagnosis has a ripple effect on their whole family structure and community. And this is where our social workers play such an important role. Perhaps they couldn't work. Perhaps there's an issue with a husband or a child or whatever that really plays a role. And then if you are interested in things like that, you can just Google this, because I think it is important. And again, you perhaps have the time and the opportunity and the relationship to better discuss these things with the patient. This existential event leaves patients with a lot of questions. And, just go Google radical remission strategies, and you will find quite amazing results. That there's more and more evidence coming out to say that there are certain things that we really can do to improve not only a patient's outcome, but also the patient's experience of the healing journey, which may or not result in cure. So, it can actually still be a healing journey without the patient being cured of their cancer. It sounds like a contrasting idea, but it really can be true. And this is where we look at diets, taking control, empowering patients to take control of their own health, to learn to follow and to trust their intuition, to use certain supplements wisely, not all the crazy things that's on the internet, but there are things that can be useful for them to use, releasing suppressed emotions, increasing positive emotions, embracing social support, deepening a spiritual connection, however that may look, and having a strong reason for living. And in essence, helping them to not miss the potential gift that a really hard journey could have given them. So that is my story. So I hope you now have a little bit more language and better understanding of how to discuss your patient's journey with them. Is there anybody with questions?